So I'm John Duke. I am a physician and scientist at the Regenstrief Institute, where I lead our drug safety informatics laboratory. I am a researcher in the field of drug safety related to clinical decision support and data analytics, and have been here since 2008 at Regenstrief and IU.
I'm Davide Bolchini, and I'm associate professor of human-computer interaction in the School of Informatics and Computing. And I'm also serve as department chair of the human-centered computing here in the School of Informatics and Computing. And I've been collaborating with John and the Regenstrief Institute in the past 7 years.
The origins of this project link very, very directly to the challenges that the medical informatics and healthcare community has had advancing safety through clinical alerts and guidance to physicians. So for many years, it was assumed that if you told physicians this is a safer way to prescribe, this is a way to avoid interactions, avoid allergies, that doctors would listen. But as it turns out, it's very complicated to give that type of advice. And with the pace of information coming into physicians, both information overload as well as other factors, we found that the rates of ignoring or disregarding recommendations was extremely high, ranging from about 80 to 95%.
Yeah, I remember when we were talking about this large problem in clinical decision support, and John was telling me about these big issues of ignoring recommendation. In our conversations, I remember we were working with our students on these types of issues. In our conversation, the idea came up in the talking to each other, and we thought about let's look at the literature, what has been done in this field. We looked at the results of this research, and over the past 20 years, we haven't seen much progress in that. So we thought about what are better ways to try to address this problem. And so in the conversation, the idea came out of starting to look not just at how alerts are designed, but maybe we should start looking at how physicians talk to each other, communicate to each other, when they share advice about medication prescribing.
And that was the key sort of nugget of discovery right there, which was that we realized, okay, well, why don't physicians trust computers? And then we said, well, why do physicians trust anybody? Why, when do they listen to anyone, including their colleagues? And I think that was really the seed that made us say, well, let's take a step back and just look at physician-physician communication and trust and advice, and derive from those principles how we can improve the sort of electronic computerized delivery of information. This project was a great integration of the sort of clinical domain and the human-computer interaction domain, the HCI, methodologies, because what essentially we did was we went in like anthropologists into the hospital system, and we sat with teams and we watched them interact. And these are teams of 7, 8 individuals across different domains, pharmacists, therapists, interns, residents, medical students, attending or staff physicians, and we looked at how they interact, and particularly around discussions of medications and prescribing, and did very, very rich documentation, both in terms of themes that they discussed, keywords that they mentioned, photographs, and all the other elements to really capture that experience and then go back and interpret. And then Davide and his team took the methodologies from HCI to really draw that out. Maybe you can describe how that was
I think the most creative aspect of the work is really not try to optimize first the alert, but really rethink or observe these fundamental behavioral dynamics of how physicians communicate to each other. So our researchers, our team looked at, for example, how physicians talk to each other, the nature of the language that they use, and also basically the disconnect between when they make decisions in a team about medication prescribing and then when they have to execute this decision on their own with their own clinical support system. And so there is an ecosystem of factors that really drive those decisions every day, and we wanted to really dissect those factors, understand what really counts when physician needs to make decision and trust each other's advice. Now we are exploring a variety of alternative designs that really embed what we call these modifiers, which are cues that really are potentially driving compliance with alerts because they are based on principles that physicians use to trust each other in their clinical setting. The next step is to prototype this alert in an interactive way and test this alert with physician in a lab setting to quickly iterate and improve on our design based on the physician response. So understanding how physicians respond to this alert in a very iterative and fast fashion is fundamental to basically improve the design and understand what are the good candidate design that is worth moving forward with the implementation and the deployment in the clinical systems. And the way we are validating that is, asking physicians how they would respond to this alert, capturing their behavior, capturing their navigation and interaction, whether they cancel a given medication, whether they or ignore an alert, and then capturing their response to these prompts.
And Regan Streif has worked in innovating clinical decision support for almost 40 years, and we design systems and build tools that are used by providers every day. And so the idea is to take what we learn in the laboratory and then begin designing alerts that we can test out in real-world settings. And so that's the longer-term objective here, and both in our system, but also more broadly to, as Davide mentioned, vendors nationally who do provide these systems to the bulk of practitioners. And so we want to see that come out, and I think that's the long-term objective.
Yeah.